Hi, my name is Spencer Freeman. I am going to be hosting this webinar. Thank you so much for coming. We're really glad you're here. There's a few people that are still joining the meeting, so I'm admitting those as I am talking. You'll have to forgive me. This is uh, my passion, not my daytime job. So we're all going to work together. All right, I'm learning as I'm going too. So hopefully that makes me just like you all. So welcome to this first of our two-part webinar series. We're going to be focusing on patient perspectives in the ICU. Again, my name is Spencer Freeman. I am the patient advocate for earlymobility.com, and I'm also sort of a volunteer helper over at the SIB Center in Nashville, Tennessee. And I'm also a survivor. So I'm a critical care survivor as well as a critical care advocate. In 2016, I spent the entire summer in the ICU. So that's how I found myself here. And how I find myself in this position. So today we're going to be talking about what it's like to be an ICU patient from the patient's perspective. The interesting thing about today's session is that we will also be joined by patients who are providers themselves. So you'll be hearing really unique information that you can't get everywhere, and we're hopeful that it will be really impactful. So first, in a minute, we're going to hear from Dr. Ely. Dr. Wes Ely is one of my most favorite people on earth. He is also in charge of the SIB Center in Nashville, which I mentioned before. And I'm going to give you a quick intro for him, and then we're going to let him talk, and then I'll introduce our other speakers for today. So Dr. Wes Ely is a critical care physician at Vanderbilt University Medical Center. He is also works at the Tennessee Valley Healthcare System and is the founder of the SIB Center and author of Every Deep Drawn Breath, which is an amazing book about his life and career as an ICU doctor and a lot of patient stories. And I'm really proud that he's my friend. For a long time, people like Dr. Ely didn't want anything to do with me, and for good reason. And when I got to the SIB Center, I thought I was going crazy, and he told me I was home. It's hard to tell you all how powerful that is. And to have him speak now is quite the privilege. So, Dr. Ely, the floor is yours.
Thank you so much, Spencer. And thank you, friends, for being here today. Can you hear me okay?
Yes.
We consider it a privilege to have you join our SIB Center family. SIB stands for Critical Illness, Brain Dysfunction, and Survivorship, CIBS. And that last S that makes it plural, survivorship, SIBS. This is such a critical piece of your life story. How has your life been affected as you go through what is actually your life in these weeks and days, weeks, and months of your life after a critical illness? And what we want to do is be part of that story if you'll let us. We consider it a privilege to learn from you, to listen to what you're teaching us and telling us about how you're living your life now, ways you're suffering, ways you're flourishing. And that word flourishing is so beautiful and important for us. How can we create a community? That's what this is becoming in many people's lives, a community where people can share with one another the things that work and don't work as they're trying to rehabilitate their brains and bodies after critical illness. And I'm going to start with a story. I see that we have 50 people on today. That's amazing. And some of you are actually groups of people, so there's more than that overall on. And I'm going to tell you the story of Todd Boland. Todd was a patient of mine in the ICU, and I wrote about him in Every Deep Drawn Breath. I call it EDDB, EDDB, Every Deep Drawn Breath. That's from Steinbeck's East of Eden. And I thought I would start there because the power of human story is what really moves us. After this, I'll give you a couple of other thoughts and hand it back over to Spencer and Kaylee. But here you go. As our patients re-enter their lives, our aim is to support them every step of the way. My patient, Todd Boland, almost died from sepsis stemming from sinusitis, simple sinusitis that developed into sepsis. He needed help to return to his job on a farm as a jack of all trades. And Lydia, his wife, tells us how difficult it's been. Even though he received early exercise and mobility interventions, walking the length of the ICU halls with his young son skipping at his side, he still experienced muscle loss and profound amount of it along the way. Minutes of activity now, months after the ICU, leave him completely winded. Studies show that mechanically ventilated patients lose nearly 20% of their muscle mass during the first week of the ICU. And they could rapidly age into frailty as assessed by a clinical frailty scale based on factors including physical activity, cognition, dependence on others for day-to-day living. Physical impairments that usually take years to develop may come on with only days of ICU stay, even for younger people like Todd. Post-ICU care, got one more paragraph. Post-ICU care is crucial if recovery is to be possible. Soon after discharge, we arranged for physical therapy sessions for Todd in his home so that he could strengthen and condition his weakened muscles. Next, the therapist went to the farm with him to assess the requirements of his job and had him work on exercises with practical applications like climbing in and out of his tractor over and over again, or carrying heavy bundles of rope on the farm. When it became clear that Todd needed cognitive rehabilitation too, an occupational therapist worked with him. His memory wasn't what it used to be, and he had trouble grasping the correct sequencing to get tasks done on the farm. Again, the therapist came to his home and to the farm to understand what would be the most helpful for Todd. She assisted him with learning to clock in at work, how to use the computer, and to develop systems that could jog his memory. When I checked in with him recently, just over a year after his discharge, he had returned to work full-time and felt that he was well on his way to being back where he was before. Now, that's not true for everybody after the ICU. There are many people we find that a dozen years later are still suffering from powerful effects of cognitive impairment. And in fact, we're going to publish a study later this year. We're working on the paper right now to submit, where we're going to show that about half of people get what's called a persistent but non-declining cognitive impairment, and another half of people develop persistent cognitive decline. And what divides people into those two groups, we don't know yet. We're determining that, but it has to do with baseline education, the numbers of comorbidities you've got, and other aspects of your ICU care, like were you medical versus surgical ICU admission. And these things all will play individual roles in your own lives. You've each lived through these different aspects and are where you are. And we want to hear from others today who have survived through this. I will say one more thing, that we want you to have resources. In the back of EDDB, I created a section called resources, and I'll read you the intro paragraph and tell you what it contains. As I considered the best way to present practical tips for you, torrents of rain pounded on the tin roof of a mountain cabin that I was visiting with my wife. I heard branches breaking and thunder clapped overhead. In the middle of such a treacherous storm, my safety felt tenuous. It made me think of other precarious times in my life and of my patients and the tenuous times in their lives. And I ponder your future and the need for refuge from a squall. In times of crisis, this is all we really want: shelter from the storm. And so in this section, we've got advice on tips for dealing with delirium, preventing that, resources for the medical team, tips for anesthesia, general guide to PICS, post-intensive care syndrome, during and after. We've got cognitive and mental health aids, physical remediation, boosting your brain health. All of this is there for you. And we at the SIB Center want to be part of your lives, and we want to just do what we can to serve you. Bottom line is that we want to dive into your chaos, and we want to do what we can to provide lifting and healing. In general, the Walk for PICS, which is now so popular and growing dramatically each year, is to raise awareness in society so that doctors and nurses and all healthcare professionals, as well as your wives, your loved ones, your family members and friends, will also know what PICS is. Because all too often, it's an invisible illness that you have acquired during your ICU stay. And you have told us that it's lonely and it's scary and it's hard. And while I don't know what you're going through because I don't have PICS, I am sorry for your suffering, and we want to be here to do what we can to help. Thanks for letting me give you a couple of introductory comments. I'm going to hand it back to you, Spencer and Kaylee, and I appreciate all of you. I'm going to head on into the hospital in a few minutes, but thank you so much for letting me be with you today.
Thank you, Dr. Ely. Really appreciate that. Um, so I now I'm going to get to a little bit more of the business part of this, and then bring on Kaylee. Before we get started, again, remind everyone to mute their mic and switch to speaker view so that whomever begins talking, you'll be able to hear them. Again, before we get started, I want to remind you all to go to a couple of websites. Jenna and Margaret are going to be putting stuff in the chat, so be on the lookout for that. We want to go to icudelirium.org, which is the SIB Center website. I'm going to walk for PICS.com, which is our website that we use to raise awareness and hopefully other stuff for this. So please check it out. We're very, very proud of it. We've got socials and all those kinds of things. And I'm very proud that I'm the patient advocate for earlymobility.com. Margaret's here and she's the CEO there, and they're going to work really hard to not just provide these kinds of webinars, but to change culture in the ICU. So please check out earlymobility.com. It's very cool, and it's something that means a ton to me. So what are we going to be doing today before I get to Kaylee specifically, right? We're going to be talking about post-intensive care syndrome from survivors who also happen to be providers from their perspective. We're going to clarify their lived experiences, right? What was it actually like to live in their bodies and minds through all of this? Offer those insights that can come from these particular people that we might not be able to get anywhere else. We're going to hopefully validate them and make them feel better because they worked really hard to get here. It was very, very painful. It was hard for them to survive what they went through and to make it here to you today. So we want to make sure that they had the opportunity to tell you what that was like so that you can avoid it or that people you love can avoid it. And then finally, as Dr. Ely said, we want to equip people with tools. We want to equip every morning I wake up and I think, how can I make Jenna's life easier? Jenna McDonald, who's the uh, uh, social worker at the SIB Center extraordinaire. How can I make her life easier so that she can make mine as such? Right. So the better patient, you get better care. And what we're going to be talking about today, there's specifically three people in addition with Kaylee. Now, Kaylee can introduce herself, but Doctor, right? Can I say Dr. Kaylee, or do I just not embarrass you?
It could be Kaylee.
Okay, Kaylee is my friend. She is a nurse, and this webinar wouldn't be happening without her because she saved my life. I don't want to get into details to embarrass her, but she takes very good care of me, and I don't know where I would be without her. She also is a mom and a wife, and she runs Dayton ICU Consulting and all these other things, and she has a great podcast, and she's going to be telling you about her experience. We have Lee Powers, who is a registered nurse, who's going to be telling you about her illness as it relates to a workplace accident and how she got better from that. We're going to be talking to Vanessa Abraham, who is an SLP, who had Guillain-Barré syndrome. She was able to recover from that. And then finally, our Jen Chap, who is a family member, a very, very close, her spouse got sick. And so she's going to be talking about PICS family. We're going to be talking about a lot of stuff here, but those are the people we'll be talking about. You'll see their bios in the chat. Vanessa has written a book that you can Google. It's Speechless, I believe, is the title. Lee's working on a bunch of things. Jen is just amazing. And those are the people we'll be talking to. So without further ado, Kaylee, you want to get started and start this conversation?
Sure. I started my career in critical care medicine in 2012 into an ICU that held almost every patient awake and usually walking during critical illness, even when they were on the ventilator. And I thought that was normal. After a few years, I became a travel nurse, and I went into other ICUs in which every single patient on a ventilator was in a medically induced coma. Unfortunately, I didn't understand the risks of that. I didn't know what patients really experienced during and after. And so the culture is so profound in those ICUs that I just went with what was normal, and I treated patients that way. It wasn't until 6 or 7 years into my career that I serendipitously sat next to an ICU survivor on a plane ride and finally what it was actually like to be a patient in the ICU, especially to be sedated and to have delirium. And that was really shocking. What impacted me probably the most was what he shared with me about life after the ICU. And I just was really upset and enraged that I had practiced for 6 or 7 years in the ICU with hundreds of patients, and had never been told or learned what it was actually like for them. I thought all sorts of things that were wrong. And so I spent the next few years interviewing people for my podcast, survivors, to learn from them, people like Spencer, what it is actually like during and after the ICU. And that really changed my perspective on what we as clinicians do in the ICU. So I want to thank you as survivors for being on this call, those that are presenting today, for being willing to share such vulnerable, intimate, and really difficult things. Your voices will save and protect future patients. And I have heard, like has been said, from many survivors that this is a very lonely path and they feel like clinicians don't care. Most of us absolutely care. We need you to speak up and speak out. So I'm really excited to be kind of facilitating the discussion with Lee, Jennifer, and Vanessa. And I'm going to be bringing in kind of the clinician perspective. For example, for many years, I thought that that patients were sleeping. That when I gave them sedatives and I had started the IV pump, that I was leading them to drift off into sweet, peaceful dreams. Lee, I want to hear from you. What did you actually experience when you were sedated into a medically induced coma during your time in the ICU?
Thank you, Kaylee, and thank you everyone that's attending. This means a lot that you're here, and I'm delighted to talk to you about a difficult situation. I want to give you a little bit of context. The last thing I remember before I was intubated, and then I'll give you some details and some examples, were about 15 residents and nurses and staff coming into my hospital room in white coats and protected equipment. All at once. Yes, it was like being in a sci-fi film. Yes, it set up my induction into the ICU in a very scary way. Then the last memory I had before intubation, or as they were intubating me, was I'm thinking something is wrong. There were complications and I can't breathe. When I woke up in the ICU on the ventilator, I felt like I was seasick. I felt like I was in a haze. I could not move, couldn't see, but I could hear, smell, and feel. So I'm going to ask you to think about, what if you were wheeled into surgery and the team thought you were anesthetized and asleep, but you were aware of everything the team was saying and you could feel every cut of the scalpel on your body. That's kind of like what happened to me. So I had some thoughts because I could hear and feel and smell. And I thought I was kidnapped. I thought I was abducted and taken to a different country. This will mean more in a bit. I'll explain that, but I want to kind of give you some context. I thought my organs were going to be harvested. I thought my teeth were going to be removed. And how many of you listening to this think, I've heard this hundreds of times, she was having hallucinations and delusions, and this is no different than care that you might experience every day if you are a provider? Probably a lot of you. What if I asked you to consider something a little different, though? What if the care that I received, and maybe others, and the manner in which it was provided set me up to experience these delusions and hallucinations? I'm going to repeat that one more time. What if the care that I was provided and the manner in which it was delivered set me up for delusions and hallucinations? So what happened? I had a fever of 105 degrees. I had pneumonia. I had a collapsed lung, UTI, and then sepsis. What do we do as providers or clinicians? A lot of times hypothermia is used to reduce the fever. So I'm wrapped in a blanket and they're doing cooling for me to make sure my fever comes down. My thought process is, I'm on ice. They're putting me on ice because they're going to take my organs. There was not one staff member, with the exception of one physician, who ever that I recall spoke directly to me. There was talking going on in the ICU. They were speaking to one another in a language I could not understand. They were speaking a foreign language. So no English was being spoken. They didn't use my name. They didn't tell me what they were doing, who they were, or why they were doing it. So if you can see, this is a setup for my brain, our brains, to try to figure out what is going on. When we don't have direct answers, we try to figure it out. Footsteps meant people, people meant pain. Every single cell on my body was on high alert. Also, I'd like you to consider what happens if someone can't see. And a lot of times in the ICU, eyes are closed, at least, for the time that you're not up and moving. I was not privy to the early mobility things that are going on now. So my experience may, have been a little different. But when one sense is taken away, so if you can't see, other senses become hyper alert and hyper vigilant. The amygdala in my brain, of course, became activated. And when it stays activated, there are all kinds of problems that can occur even years later. So again, I'm not understanding the language. I'm not being given any explanation. People are coming in and prying my mouth open. I hear a drill sound. I thought they're taking my teeth. They're actually cleaning my teeth, but nobody is telling me what's going on. And the more they're prying my mouth open, the more I'm trying to keep it closed. I also had very, very poor hygiene. When I finally came off the ventilator and my arms were finally loose, I remember moving my hand up and touching my head, and my hair had not been washed. And that entire time, it's plastered to my head. And I'm thinking, this must be a foreign place, a foreign land. There's no way this can be a US hospital because the hygiene is so bad. The other thing, the last example that I want to share for this segment is I was given a stool softener daily. I had liquid diarrhea every single day. It felt like every single moment. The staff would come in, throw off the covers. I'm laying there, in restraints, my arms straight out, freezing, and they're coming in with cold, coarse washcloths, cleaning me from this constant diarrhea. No one's really questioning why I'm given a stool softener when I have this diarrhea constantly. My mind was saying, where are the warm, wet wipes? I had sores, abrasions, bleeding. My private parts felt like they're going to be peeled off with the constant cleaning. And the staff, when they'd come in, they'd make this clucking noise, and I could feel the disapproval. They're exasperated. I'm exasperated too, but I can't move. I feel bad for them, but I can't communicate. And every single second that they'd get me cleaned and regowned, a rush of liquid diarrhea would begin again, and I'd lay there in the worst smelly mess you can imagine, over and over and over for 21 days. So that's what I wanted to share for this section, and I'm going to turn it back to you, Kaylee.
Yeah, I think when you talked about the clinicians just assuming, well, that's normal. That is pretty normal for patients become so confused, delirious, and as clinicians, we sometimes accept it as normal. We assume that every patient's going to be crazy on the ventilator, right? How would you recommend as a survivor that we help minimize those hallucinations and delusions? I don't even like to call it that because I know for you as survivors, it's so real, but how do we keep you in reality?
So there's a lot. Thank you so much for asking that question, Kaylee, because as a nurse, I'm laying there thinking with drugs that are very powerful, some of which, as you all know, are actually geared towards making you forget. And I am holding on with all my might, trying to remember, because I'm thinking, if I make it through this, I need to wake up and I need to be able to share it with folks like you. I need to share it with other staff. Some of the things aren't as difficult as you might think. Making sure with every interaction that you're treating the person in the bed as a person and not just a body. Every time, I don't care if it's the cleaning staff, the environmental services, physicians, OT, PT, nurses, every single person I think that enters that room should identify themselves, use the patient name if they're going to interact with the patient, tell them what they are doing, why they are doing that. If I had some explanation, you're going to be cold. I'm sorry. You have a fever. Give us some reason for the intervention. Yes, there's a lot of interventions that are painful, but just talking to the patient and imagining, even though they look asleep, that they can hear you would be an excellent start. There was one particular doctor, and I think she saved my life. She was the only one that I can remember that came in my room every day, twice a day when she was on shift, held my hand, used my name, and spoke to me in English and asked me to wake up because I had difficulty waking up. The coma was supposed to last 5 days. It was actually 21.
Lee, what I'm hearing is that doctor speaking to you and touching you and being with you changed everything.
Absolutely.
So we hear the power of presence, like that. There was no prescription, there was no injection, there was no procedure. There was a doctor who took a hand and made eye contact. Vanessa, you're an SLP and a survivor. Would you briefly introduce yourself and give us some of your feedback on the stuff you've heard already, and some of the stuff Jog Drex, you nodding a few times. So quickly tell us, like Lee did, who you are and what you want to briefly respond to there.
Yes, a lot of those things that Lee was just talking about brought up so many memories for me of my ICU stay. I was actually sitting here writing down little notes because I was thinking in my head, yes, that's right, I remember that. So let me back up a little bit. I am Vanessa Abraham. I am a speech pathologist. And 5 years ago, I came down with, as Dr. Ely said, a life-threatening illness that paralyzed my brainstem and spinal cord within a matter of a week. It's amazing how quickly these things can come on. My stay in the ICU was a little bit different than Lee's, though. My ICU stay was actually, I don't want to use the word pleasant because it's never pleasant in ICU, but I felt like I was treated very well. They really treated me like a human being. They did an exceptional job of realizing that I am an SLP, I am a mother, I am a wife, I am a daughter. They looked at me and, like Lee said, when they walked in the room, they were greeting me, even though I may not have been very aware. But they would say, "Hi, Vanessa, you know, my name is Rachel. I am going to be doing this, and this is why I'm doing that." And I look back at my ICU experience with a lot of gratitude because of the care that I received. However, when I transitioned from the ICU to my LTAC, that's when everything changed for me. That's where the level of care changed significantly. I was woken up in the middle of the night by not nursing, but cleaning crew yelling at me. I was yelling back at them. People trying to get blood samples from my veins that were so collapsed and damaged from the ICU. And I have very vivid memories of all of us yelling at each other. The level of care, they would walk in my room. They would never introduce themselves. They would never tell me what they were doing. They would wake me up in the middle of the night when I'm trying to sleep and heal. So that part for me was a nightmare. One thing that did kind of bring up a memory for me when Lee was speaking about my ICU experience was being a speech pathologist. I was not given proper AAC devices. AAC, augmentative alternative communication. And as an SLP, I was perplexed I was laying there thinking, okay, all you guys have for me is a piece of paper with letters on it. This is 2019. Where's your iPad with touch chat, Proloquo to go? Where's your high-tech communication devices? You're just giving me a piece of paper? Although I was somewhat paralyzed, I could still type. So the SLP in me at that point was thinking, okay, somebody give me my phone. I know there's a free download of a text-to-speech. So once I gained more awareness of my surroundings and my fingers, I could type a little bit with my fingers and I got more mobility in my arms. That's when things started to escalate for me and get better in terms of being able to communicate. Because for me, not having a voice and not being able to ask questions to my team and say, what are you doing? What's my prognosis? What the heck happened to me in the past 3 days? I've been unconscious. I felt totally out of control because I didn't have a voice. I couldn't ask questions. I was aware, but I was speechless. There's my book title, Speechless. Because I couldn't ask those questions, and being out of control for me caused such immense anxiety. I wanted to know when my next MRI was going to be, what the results were, what the results of these blood tests were. Where's my daughter? I wanted to know where my child was. Is she okay? Does she need me? Does she miss me? Sorry, I'm going to cry because that is hard for me. I couldn't ask where she was or if she was okay. And I wanted to know and I couldn't. So for me, not having access to proper communication was a big pitfall in my experience in the ICU. Since then, it's changed, I've heard, but I was just really shocked that in 2019, they didn't have anything higher tech for me. And I'm grateful that I was an SLP and I realized that. But if I was just an average patient and there wasn't an SLP, they wouldn't have known to, hey, I can go on the App Store and download text-to-speech. But I knew that, and if it wasn't for being an SLP, I probably would have laid there and been more anxious because I didn't have a form of communication.
Yeah, so Lee, I mean, Vanessa, let me jump in there. Now, Lee has said similar things to you that what could have been an asset, your knowledge and skill and experience, quickly became a liability inside of your head. And it makes me wonder, Kaylee, with your professional experience and personal experience that you so wonderfully deal with on your show and all this stuff, what does that make you think as a professional that is hearing this? Like, okay, well, it was just the moments where they were treated like a human, no?
Well, for 7 years, I had most of my patients on ventilators awake and writing on a clipboard, texting on their phones. But the reason that was able to happen was because we didn't even give sedation unless it was absolutely unavoidable. So they were allowed to wake up after the procedure of having the breathing tube placed and had their cognition and their fine motor skills intact to be able to use those tools. And at the time, I don't think I really valued it like I do now, the power and the importance of patients being able to communicate. They are the experts on themselves, their own bodies. There's a huge ethical problem in my mind of not allowing patients to be informed, consent, and be autonomous over what's going on in their bodies and their lives in one of the most critical moments of their lives. Vanessa, your story about wanting to know about your daughter, I mean, as a mother, that would be my first question. I've got a daughter with special needs. I'd want to know about her medications. You know, if I couldn't ask those questions and get those answers, I would be trying to climb out of bed. I would be pulling that tube out. I'd be out of there as much as possible. And I've had patients, especially mothers, ask about their children as some of the first questions, if not the very first question, they write on a clipboard. Where is my child? And in the ICU, we don't value patient communication. We don't think about it. It's part of the dehumanization that happens with critical care or critically ill patients, is that we're focused on the kidneys, the lungs, certain organ systems, but we're forgetting this person as a whole and their right to make decisions and be informed along the journey. And I've been impressed to learn from family members how that impacts them as well. Being married, I never go days to weeks without talking to my husband, but that's what we do to our patients, they go days to weeks without talking to their loved ones. So I want to hear from Jennifer. I'm going to pass the ball to her. What was it like for you, Jennifer, as a wife with your husband in the ICU? How did this kind of care impact you in and after the ICU?
Well, thank you, Kaylee, and thank you everyone for having me. And I'm really grateful to be here and share my side of the story. After listening to the previous two speakers, I'm actually glad that my husband has very little memory, if any, of what happened to him. But I carry all those memories because what happened to him happened to me as well. I identify myself as a co-survivor precisely because what he went through, I was right with him by his side every moment from the start. And when it's a life or death issue that affects a family member, the loved ones are affected as well. I'll just briefly kind of share just some perspective about my situation. And, you know, it was a shared trauma for both of us. And so we as co-survivors have our own profound journeys of survival and recovery. It's just different than our survivor or my husband in this case. But once both of us kind of recognize that, you know, in recovery, that both of our foundational safety had just been ripped out from under us, it was a big turning point for us. It was a real aha moment. And that didn't happen until about 6 months into recovery. Once that happened, we were really able to move forward and kind of balance all of the things that we were feeling, from gratitude that he survived to grief for the things that we truly lost. And then for me, it was guilt for feeling grief when he had such a positive outcome. So it's this kind of strange dance that we all go through, but co-survivors kind of have to suffer it a little bit in silence because we aren't the patient. My journey began really in my home office with my cat, who started meowing and jumping, trying to get my attention. And fortunately, he did. And that's when I found my husband, Rick, collapsed on the floor in the kitchen, non-responsive, gasping for air. I immediately called 911, and within a matter of seconds, he took his last breath in my arms. And I didn't know it at the time, but he was in sudden cardiac arrest. His heart had stopped, and he was clinically dead. Luckily, the 911 dispatcher, who was my coach and was with me the whole time, was able to talk me through dispatch-assisted hands-only CPR. I gave Rick 10 minutes of CPR until EMS arrived and took over. And then I stood back and I watched as they resuscitated him. It's not like the movies. They don't just wake up, or he didn't just wake up. After they did manage to get a heartbeat, I watched them intubate him, and then I watched them bag him all the way to the ambulance waiting outside. I couldn't go with them in the ambulance because he was too critical. But when I did arrive at the hospital, and we had a really wonderful hospital experience, I'm just going to say that right now. I was met at the door by a hospital clergyman, and that was really comforting because I was in shock, having just literally had my husband's life in my own hands. And so he escorted me to that little room in the ER that nobody really wants to go to because it means your loved one may not make it. But the chaplains there were with me through that whole experience in the ER and really throughout the day. And they were such a calming influence and gave me really a safe space to be able to cry, feel, all of those things, start to process. But I barely had a chance to catch my breath before, of course, the doctors wanted to get vital information from me about what happened. And so I was peppered with questions, on and on and on in the ER, obviously trying to convince them that, yes, he was in agonal breathing, that I later learned it's called, when I started right when I found him, because they want to make sure he's viable to continue to save. I didn't know that at the time, but that's kind of what they want that information for, to make sure that his brain was not without oxygen for a long period of time. So after many, many, many questions, I do want to share one thing that was, to this day, the really most important thing for me, really, that helped me throughout the ups and downs in the ICU, the step down unit. And that was, one of the chaplains brought me a blanket, and I have it with me right here. And I'm just going to pull it up. This blanket. And this blanket was knitted by women in prayer at the hospital in the spiritual support area. And they gave me that blanket, and I wrapped it around me, and it felt so powerful and comforting. And it made me feel like I was being hugged by an angel. Because when I was giving my husband CPR, I really felt like my knees and feet were in this world, but my head, hands, and heart were somewhere in between heaven and earth, because I was trying desperately to pull my husband back into this world. And I share all of this only to say that before Rick ever got to the ICU, I was already very traumatized myself. So when I did finally get to see him in ICU hours later, and he was hooked up to all kinds of machines, and he was cool to the touch because they had placed him in therapeutic hypothermia to protect his brain. Hearing the beeps of the machines, they were comforting to me because I knew he was still alive. And so it was just hurdle after hurdle like that for me. And so my role as a co-survivor has really evolved over time, from literally being Rick's heartbeat to being his caregiver in the first 6 months post discharge. And as Rick became more independent, I became really a little bit more of his champion, trying to encourage him and help him re-engage with life, as Dr. Ely described. And when he completely was independent, I had to step way back, and my hypervigilance I had to turn it down a big notch. And that's really when I could focus on taking care of me and trying to process my own trauma and get help. But it was 1 year before I actually got a therapist to help me process that. And it was such a terrifying thing when he was in the ICU. He was in therapeutic hypothermia and unconscious for 4 days without knowing whether he was mentally in there, whether he had brain, we knew his brain was functioning, but I didn't know who was going to wake up, if he was going to wake up at all. So for me, I leaned a lot on, the humanity of the people around me. And it was an interesting feeling because it really made me really understand and see the good in so many people that I would have normally just not even paid attention to. I was in such a vulnerable state that it carried me. It really helped to carry me as a family member. The other thing that is important that I mentioned before I pass this off is that I've learned since that, at least in our situation, and mainly because in the case of cardiac arrest, most cardiac arrest survivors lose their memory for a period of time. So Rick doesn't remember 2 weeks before it happened, and he barely remembers anything in the hospital, just bits and pieces. So when he came home from the hospital and as he started to get better, he was all about just returning to life. I mean, he didn't really have the same kind of memories that I had versus my memories where, I could remember every single detail of what happened to him to get into the ICU. And I remember every moment waiting for him to wake up. And at one point, they even told me I couldn't touch him because they didn't want to excite his brain. That's why they put them in uh, induced coma. So, we come at it at from different points of view. And once we finally realized that I can never understand really what he experienced, and he understands that he can never understand what I experienced, we became a lot more able to communicate about this experience and understanding of each other in general, even though, we experienced it differently. And that was really helpful. So I guess I say that to remember that even though, people that come out of ICU may be a little different, and Rick is a little different, it hasn't changed our relationship once we really learned how to communicate post ICU.
Thank you so
Communication
much.
is key.
Yeah, well, yeah, thank you, Jennifer. There's so many insights and perspectives that I was not aware of for so many years caring for patients in the ICU. Obviously, I think we recognize that families are under a lot of distress. This is very traumatic, but I don't think we really understand what life is going to be like for them after the ICU. So there's an inability to fully prepare patients and families for life after the ICU. I want to ask Lee about what kind of challenges did you experience after your ICU stay, and what's been helpful during your recovery?
Mhm. Thank you, Kaylee. So initially, because of the length of time that I didn't have the early mobility, I lost a good bit. I don't know what percentage exactly, but I lost, a lot of my muscle mass. So I still remember the very first time after getting discharged from the hospital. I was in a hotel and had a friend of mine, a nurse, with me. It literally took me 4 hours to crawl from the bed to the bathroom to try to get in the shower. And then, of course, I couldn't get myself in the shower. And I didn't even have enough strength to hold the shower arm. So I had to have someone help me with bathing, redressing, everything. And it was like an inch or two and then take a rest on the floor, and an inch or two. I mean, it was painful, and just I was horrified because I walked in as a runner and I walked out as someone that had to learn to walk. I had talking problems, I had cognition problems. So it was like in an instant, my life changed. Also, in terms of post ICU, I'm going to share something really vulnerable. It took me 10 years before I could get up the courage to go to the dentist. And I disclosed to the dentist that I still had, that I was an ICU survivor and that I was still having flashbacks about my mouth being pried open. And so they're like, oh, this is important information. I'm telling the hygienist, the dentist, everyone. And I'm there with stuff in my mouth, so I can't talk again. And he tells me, you have very severe TMJ. We need to talk because you need to stop grinding your teeth at night. And I'm like, oh, I will, I'm not saying it out loud, but I'm like, I will tell my subconscious mind to stop being traumatized and to stop grinding my teeth. So we still have a ways to go with providers. And maybe, anyway, my thought was that maybe we should have, dental questions for survivors in admission forms or in rehab, to look at that, because it was a real vulnerability that I still have. And then just a lot of feelings and shame associated with that, because I just couldn't get myself to the dentist. The other thing that I think is important to mention, because of the trauma, I woke myself up every single night for 7 years, screaming at the top of my lungs. And if anyone wants to know what I was saying, I was screaming, "Get me out of here." So that was extremely difficult. Luckily, in terms of what helps, I have a service dog. His name is Nelson Mandela. And I don't wake up screaming every night those words. I sometimes still wake up and I'll say something, but it's not screaming. So I think I'm definitely making progress. And should I get agitated at night, he is trained to basically come and sit on me. And that has been just a wonderful thing. Swimming has been absolutely critical for me in terms of rebuilding muscle mass. And I've been able to, do normal people hikes, but a lot of self-directed rehab after just, there didn't seem to be a lot of specialization that I required in post rehab care. So as a nurse, I kind of made up my own and decided I was going to swim, with flotation devices, small periods of time, multiple times a day. And that has gotten my physical fitness back up to a level that's been extremely helpful.
It's astounding to consider that you left and you were unable to really get yourself from the bed to the shower in a hotel room. As an ICU clinician, I never would have anticipated that. I just assumed that they would be rehabilitated somewhere, that they'd be taken care of, that life, they rebuild some muscle for a few weeks and then move on with life, because we treated their sepsis, because we fixed the acute and critical problem. They're going to be back on their feet shortly after. But that is not your reality, even as a young, healthy runner. That is so astounding. And I want to ask Vanessa, what are your thoughts on what do we as clinicians need to do better to prepare survivors for life after the ICU?
Great question. Great question. I have a million things that I would recommend. Again, Lee, your stories triggered other things in my mind of things that could be done to help us post ICU. For me, my ICU stay and my hospital stays were relatively short. The long haul for me is dealing with the PICS, the post-intensive care syndrome, the PTSD, the depression, the anxiety associated with my brief medical stay. So even though my ICU stay was a month, rehab was a month, the past 5 years have been extremely challenging. Lee, you talk about your dentist. I'm going to share a vulnerable moment too. Yesterday I had a mammogram, and for me, just to walk in that building, even though it wasn't another brain MRI or another IV infusion of IVIG immunoglobulins, just walking back in that sterile environment with the white walls, some foreign person touching my body that I don't know, a white machine, white flooring. The tech was very nice and a nice woman. However, she probably thought I was very cold and rude because I really wasn't talking to her, because little did she know that the whole drive there I was crying. The drive home I was crying, just because of the anxiety of walking back into a medical establishment. It had nothing to do with my diagnosis of Guillain-Barré. It was just a routine doctor appointment. But those are real. So that long-term effects of dealing with an ICU are real. Another thing that I think can be done is the educational system needs to be educating clinicians, even social workers, pharmacists, everybody needs to be taking a course or listening to webinars such as this to learn strategies and gain some necessary skills when you're working with patients like us. Like for, just the example of yesterday, this woman that was working with me, she was very nice, but she didn't know, just like Lee, what we were dealing with upstairs. She doesn't know that here, this was a woman that was in the ICU fighting for her life and my history. So for me, that is a big one. And universities needing to educate, having, it doesn't need to be a whole class or a whole textbook, but having these conversations to me is huge. One other thing that I wanted to discuss is when I was sent home from the rehabilitation hospital that I was at, they did a phenomenal job of preparing me with all the necessary cartons of tube feed because I was tube fed. They sent me home with all sorts of medical equipment such as shower chairs, commodes, suction devices. I had all of the equipment that I needed to come home. And I remember sitting on my couch looking at 5, 8 boxes of cartons of tube feed and thinking to myself, what good is all of that tube feed at keeping me alive when all I want to do is die? I would look at that food, cartons of tube feed that my husband had to pump into my stomach and think, I would rather die. So what good is all of the medical equipment that the insurance was so great in providing? They've got to do that, but they were missing the big picture. This patient, this mother, this young mother, this speech pathologist wants to die. They were missing the big picture, and I was really disappointed in that. And I remember telling my husband that I've got all this equipment, but I don't care about it. Showering is not a big deal to me. I'm just sitting here on the couch paralyzed. I need help. And no one was there. The therapist that I did see didn't understand PICS. I've been through many other than support groups like Vanderbilt and Mercy. Those have been what's kept me alive and my daughter. But the mental health services that I would just find locally would not address PICS. When I would come to them and tell them, look, I was in the ICU for a month. This is what I experienced. Somehow they would get off topic and they would start giving me advice on how to parent my child. And I'm like, that's not why I'm here. I just felt like so many people did not understand that I'm dealing with medical PTSD. I wasn't in war. I wasn't molested. I don't have any childhood traumas. But what I am dealing with is medical trauma. And these mental health therapists were trained to deal with trauma in different ways. They don't look at medical trauma as being a trauma. They don't know that the effects of trauma, medical trauma, and the effects of what it does to the vagus nerve, what it does to the frontal lobe, the hippocampus, the amygdala. They are thinking more of other trauma. So when people say, or when I say to people, like, I've got medical PTSD, they immediately think, well, I didn't learn that in grad school. No one's ever talked to me about that. That's not a thing. You're fine. You look fine. You go to work. You're a busy mom doing the mom thing. You're, living your life. And it's like, no, medical trauma is real. Medical PTSD is real. You don't need to be at war to have PTSD. And that's, again, retraining the system.
And
Go ahead, Kaylee.
when survivors are leaving the hospital, we're really good at looking at their lab values and saying, oh, you still have a kidney injury. You should go see a nephrologist. You are still on oxygen. You need to follow up with a pulmonologist. But this kind of damage and trauma is not detectable in a lab value. It's not talked about. And so we really are failing to make this a standardized part of releasing survivors back into the wild. We're not preparing them for what's to come. And I know for me and for the podcast listeners that I've been in contact with, hearing from survivors has been so impactful. It's also very distressing that we can go decades of our career without any concept of the emotional and psychological and cognitive damage that's happening to our patients in and after the ICU. So thank you so much for sharing that. It would be so powerful to have more survivors speaking out, reaching out to our educational systems, to joining together, having almost like an uproar, an outcry to say, we are not being taken care of. We have to fix this for future patients. And I think, especially Jennifer, for you as a family member, I know in the ICU, we're very focused on your husband. We're looking at his heart. We're looking at the medically induced coma. We're looking at preventing pressure injuries. You know, we are very task oriented, very system focused. We recognize that this is hard for you as a family member. You're fine. You're medically fine. And you're going to be stressed out now, but then he's going to survive and everyone's going to go home and be fine, is our perception in the ICU usually. So how can we better prepare families for the deficits that the survivor themselves are going to experience and the challenges that you as a family member are going to face after the ICU?
So that's a good question. Well, any transition was hard. The transition to the step down unit was hard because I had to meet all new people and whatnot. But where I was truly terrified was that he was going to be discharged into my care. And he was not at all himself. He still had a bit of delirium. So I was terrified, how am I going to take care of him? What if it happened again? And I just felt so alone. And I just honestly didn't even really know what had happened to him yet. So had so much to process. So I did, well, my sister flew down and was with me, and she did ask for a social worker for me to talk to, which I did, but it wasn't necessarily like a psychologist. It wasn't that kind of ICU and trauma informed person. So it was helpful, but I really needed a lot more care because I was losing it myself and terrified of him coming home. So what I would like to say, I'll just mention a few things. I think it would be incredible to have access to medical trauma psychologists in the ICU. And I know that not only for the patients, but also for the families. And as a family member, I know I'm not a patient, but I still am an invisible patient because I suffered too. So I know, and I work with an advocacy organization that made up of trauma psychologists and a lot of medical trauma psychologists. And we're trying to really de-traumatize ICUs by giving psychologists that are specifically informed on medical trauma to be available. And then the other thing I would say is, long before discharge, it would have been nice to have had my own kind of education session with somebody, because I was going to be caring for him. And, didn't really know what to do if something happened and all of those things. And phone access perhaps to a hospital care team would have been really helpful, or at least a safety net. And I strongly recommend that you give the caregiver an early heads up in advance of discharge, so that we can kind of prepare and please make sure all the specialists that come in and out know that only the hospitalist can discharge the patient. Otherwise, a specialist, as in my case, set an unrealistic expectation with my husband, and he was determined to leave and almost did, but fortunately we convinced him to stay. So he wasn't himself. And so all of that was very, very, very scary for me. The other thing, and I think it's changed now, is make it a simple, easy, convenient way for caregivers to be able to get prescriptions through the hospital prior to discharge, so that, if you don't have somebody to help care for somebody, you don't want to leave them alone when they're, not really completely in their right state. But I had my sister, so fortunately I could get his meds. And, for cardiac arrest, and it's probably true for other disease states, I would have liked to have had, you know, the opportunity for potentially CPR, proper CPR training prior to his discharge, and information about that I probably needed to get an AED just in case, because he did not have an ICD implanted. But most of all, I needed specific information about what happened to Rick, and really, and what happened to me too. But nothing existed for cardiac arrest. And that's why one of the things that I'm very involved in as a founding member of is HeartSight, which is a resource that connects anyone affected by cardiac arrest with free, clinically backed and lived experience insights to support their journey forward. And it launched a year ago, and it just in 1 year, over 42,000 unique visitors have accessed this intervention online. And for hospitals and clinicians, it's now as simple as just providing a card with a QR code on it to our heartsight.com, which has been put in the chat. So take a look at that, and you can learn a little bit more about it. But we're really trying hard to get resources into people's hands sooner, so that they don't have to figure it out for themselves when they go home. And, you know, meanwhile, their PTS is just brewing and brewing. I suffer from PTSD. So this has been very helpful, and I find advocacy in general very helpful, including my husband and I becoming BLS instructors and forming Buddy CPR, named after our cat, and teaching CPR with our fire department, and participating in a lot of other things tied to PICS. We helped organize the first annual Walk for PICS in Orlando with a couple of other organizers. And so those are the things that really have helped me the most. And I hope that it helps all of you in figuring out how to take care of people like us.
Thanks, Jen. So you guys have heard a lot today, and we're going to have some time for questions. So I want to leave that open. So if you've got a question now, go ahead and put it in the chat. You've got these people here to answer these questions, so we might as well do it. I think we're going to go back to each one of them before we go, so they can do their final thought. I will say, to tee it up for you all, you know, I spent my own personal experience of getting sick in 2016. From 2016 through COVID, through about 2022, I spent about 6 months of my life in the hospital. So if you go 24 hours a day times 180 days, I put some time in. And I can tell you that none of the things they have said that you've heard today are unfamiliar to me. I have been clucked at. I have been ignored. I have been accused of lying. I have had my family taken away from me. I've been moved in the middle of the night. I have been told I was a lot and that I complained too much. So this is universal. So before we get to the questions, Lee, I'm going to come to you first. RNs are amazing. I really don't know what else to say, because it might sound superfluous or hyperbolic, but they are, and they saved my life. Kaylee being prime amongst them. Lee, as you've heard all this, and the things that have happened that I'm telling you about have happened now, hopefully. What do you want to say before we go quickly and get to these questions that's important to you?
I think I just want to summarize and say there's a lot from all of us that have spoken, and every critical care survivor. There's a lot of loss. I'm not sure we I'm not sure we appreciate the number of losses that can occur. So for me, again, an assault at work by a patient led to me losing my job because I couldn't come back within 3 months at full capacity. I lost my identity. I lost my savings. I was finishing up my NP, my nurse practitioner degree. So I lost the ability to complete that. I lost my source of income, my independence. and ability to care for myself. So that was huge. And I'm not sure we think about the economic impact for people that have gone through critical illness. And also it does, as Jen and others have said, affect the community. So it not only hurts the survivor, but people that love you, whether they're direct family members or in the community, it's like a tidal wave that goes through and can have a huge impact. And then just to finish up, I had written something about my ICU experience and I just wanted to quickly share, and it's short. I was in the ICU on a ventilator and I could not move, could not see, but I could feel many things which were horrifying, especially if I was not treated as a person, but rather a body in a bed. You never know what patients will remember.
Thank you, Lee. That was
Thank you.
perfect.
Thank you.
Ditto. You will not believe some of the things that I remember. So before we get to Jen to talk about the family stuff and Kaylee, Vanessa, you've got this book coming out. You've got your website. You're doing all this stuff. You've heard all this now. While everyone's still here, take a minute and say what you'd like to tell the people after coming so far to get here.
Well, again, Lee, you brought up other memories. You said something about loss and grief, and it triggered a memory of me that when I came home from the ICU, barely able to move, sitting in my house, and I remember seeing people out in the community, if I would go out in the community, which was very challenging as it was, but I remember looking at my husband and saying, I don't fit in this world anymore. These are all working professionals. These are all soccer moms. These are all people living their best life. And here I am as a woman in her 30s, sitting on the couch, being tube fed by her husband. And I remember that vividly, thinking, this is not my world. This is not my life. I do not fit in this world anymore. I need to leave this world. So that was real for me. So the grief that we as ICU survivors, the loss that we experience is huge. Also circling back to what Dr. Ely said at the very beginning of this presentation about we all have invisible disabilities. I'm back to work. I'm living my best life now. Am I back to where I was? Absolutely not. We have invisible disabilities. I don't have a wheelchair. Don't need a walker. I don't need that shower chair anymore, that suction device or that tube feed. That's all behind me and in the past, but there's still a lot that we deal with. As a result of my paralysis and what I went through, I have immense swallowing difficulties. I am a speech pathologist. This is what I do. Eating for me is a miserable experience. I don't even know if miserable explains how bad it is. It's painful. But again, it's invisible. Nobody sees that. Nobody can feel it alongside with me. It's just something that I deal with. You know, we all, Lee mentioned about her dental appointment, me and my appointment yesterday, going back into these environments triggers a lot of PTSD for us. And again, that's another invisible disability that we as survivors face. So those are my big kind of takeaways. So thank you all for being here and hearing our stories. It was really hard, I know, for all of us to be here and share our stories, but knowing that we've impacted you guys in some way helps us heal as well. So thank you.
Thanks, Vanessa. That was really, really poignant and beautiful. And I, before we get to the family part, I hope all the providers hear that the answer to this is love and attention. That's it. But that's hard. That's really, really hard to love someone like me. I think you can do it. Jen, you've heard all this stuff before we close with Kaylee and the professional side of this. Before we go, you saved your husband. You're working on saving yourself, and I can't imagine any harder things to do. And here you are smiling, making me feel better about it. So what do you want to tell everybody quickly before we go that's important to you?
Well, I'll tell you that Rick and I both made a conscious decision to look forward in life and make more memories that may not have been. And every year on his rebirth day, we celebrate, and oftentimes we go back and we see those who were part of his chain of survival. So we try to find the good in it, and honestly, for me, I feel like I learned so much, and it's helping me live a better life. I don't know how to explain it any further than that. And my message, I guess, to any clinicians here is that, PICS-F is real. So do your best to help families of your patients. And while we're not the patient, we are still somewhat an invisible patient. And I'll leave you with this one last statement, is that I believe that critical care isn't just about surviving, it's about living.
I get to follow that. Wonderful, Kaylee. That was perfect, Jen. Kaylee, quickly, as a professional, and as someone who I values opinion more than my own, what do you want to say?
I've been in critical care medicine for 12 years now, and thinking back to just even that first year, I had no business being in the ICU. I'd had my license as an RN with my associate's degree for 3 years and didn't use it. I was gallivanting through the world, and then I came into the ICU. So there's so much about medicine that I didn't know, so much about critical illness that I didn't know. But I think back to the things that I did that were intuitive, like holding their hands, singing to them, giving them a clipboard to write, to sit there and learn about their lives from them while they were on ventilators. Those things I was good at because I wasn't good at much else during that first year. And now with my doctorate and over a decade later, I look back and I realize that those were life-saving interventions, that is what critical care medicine is about. Obviously, it was essential that I learned everything else, all the other care that we provide, but listening to survivors reminds me that those soft skills, those little things matter. And that is what the ABCDEF bundle is about. This process of care that's supposed to humanize the ICU, not just be extra things to do or to chart, not just things that are on the back end, like accessories to care in the ICU. It should be the core of how we care for patients in the ICU, how we care for humans, not just how we care for ventilators, how we care for blood pressure, but how we care for people as individuals, as members of a family, as professionals, as people with not just the current present in the ICU, but for their futures far beyond the ICU. And without survivors, I wouldn't have that perspective. So thank you so much for everything you guys have shared with me throughout the years, shared with the ICU community. Please continue to speak out. Please continue to go back to the hospitals where you were admitted, if you're able to, if you're there psychologically in a place to do that. Share with them what you're going through. I know it's hard to tell people that cared for you that bad things happen to you, but we need them to understand, because a lot of this can be prevented. We can prevent this damage, and we can better prepare families and survivors to deal with the damage that's been done. But we'll never get there unless we are really aware. We cannot fix what we cannot confront. So thank you for being part of this revolution. Your voices, your experiences are invaluable, and I appreciate your willingness to dedicate them to a better future.
Thanks, Kaylee. So we've got a few more minutes for questions. If anybody has any, they can put them in now. I have one, but before I do that, I want to tell you again to come to our second webinar, which is going to be on December 5th at the same time, 11 a.m. Eastern. We're going to be talking about more of the professional side of this, the perspectives from providers. Nurse Brenda Pun, Dr. Jackson, he's a psychologist. He's going to be there. They're both with SIBS. It's wonderful. our Margaret Arnold and I think Jenna McDonald are going to be speaking. We'll have a lot of fun stuff. It's going to be interesting. So please come. But more info will come. You don't have to remember all that. Please go to icudelirium.org, walkforpics.com, and earlymobility.com to see all of this stuff in pictures and in real life and in color, so that it makes a little more sense. Is there? I think I didn't share a lot about my own perspective, but I will say that I have found that Kaylee is 100% right. The answer to all these questions is intuition and humanity. And so every time it gets really scary and you think, how can I save this person? I see someone trapped in there and I don't know what to do. Well, their friend is right there in the room with you. Tell them all this stuff. Because I know for a fact that if someone had told my mother everything that you're telling us now, she would have remembered. She would have done it. I'm only here because she did everything I told her to do. So tell us everything to do. It's that simple. I did want to put to everyone really quickly before we go. We're going to be we're going to have providers talk about this next time. And we're going to be talking about the diagnosis of post-intensive care syndrome, what's happening in the chemistry, what it looks like and presents to people. But if there's something I'd like to do real quick, have any of you, the survivors that have been talking and the family members, and Kaylee, this includes you, unmute your mics. How many of you have been told or dismissed and said, this isn't how this works? You don't know what you're talking about. PTSD doesn't come from this kind of stuff. I'm guessing that without you all saying anything, you can say yes or no. Lee, I mean, you've been
Yes.
told,
Yes.
right?
Right. No,
Right. So,
yes.
yeah. So what I would say to the people here is that, not to scare you and say that's malpractice, which I guess it is. As an attorney, I don't mind saying that. But what it is, it's not the best you can do. It's not why you got into this practice. It's not who you are. Telling Lee that she didn't know what she was talking about almost kept her from being here. Right. So with that, I haven't seen a ton of questions. So maybe we did everything we needed to do. We've got just a minute left. Jenna or Margaret, is there anything that we haven't done that we need to do? We're going to have more webinars, and I would really, really like it if everyone would go on and search me on X and find the SIB Center, most importantly on X and Twitter, and promote that stuff for us by resharing it and liking it. It means a lot to us. It actually helps a tremendous amount. I know that sounds silly and everyone says it all the time. So let's see. Again, so let me just tee up finally what we were doing here, and then we'll go, since we've answered everyone's questions and appreciate you all being here.
Spencer,
I'll share
one thing you had asked me. I'll share one thing.
Oh.
If anyone is interested in any of the resources that Vanderbilt has available from the SIB Center regarding post-intensive care syndrome or ICU delirium, I'd be glad to share any of those resources with any of the providers here or any survivors who may be here. So please email me. I'll put my email address in the chat, and I'd be glad to provide any information about our groups or the resources that we have available.
That's perfect, Jenna. Thank you so much. We have support groups that are run by survivors that we meet on our own Zoom. Connie, I see your hand, so you could come. We have stuff for survivors and the providers. We have all that stuff. So please go to the website. Jenna's email is on the flyer, and all that stuff is available either through our socials and any of that stuff. So you can get to us. Please do. Connie, you have your hand raised. Please feel free to go ahead.
I'd like to challenge you all to tell everyone that doesn't run away from you about PICS. It's something that I do. I tell my plumber, I tell my oxygen man, I tell people in the checkout line when they see me, my hands trembling from the tremors that I have. What do you got to lose? You have nothing to lose by telling strangers about PICS. They may know somebody. They may be like Jennifer, whose husband came home a little bit different.
Thank you, Connie. That's such a great challenge and such a great reminder. We have to talk about this. We have to talk. No one talked to me about it. No one talked to, and I know from talking to Vanessa and Lee, no one phrased the conversation to them this way. And as you heard from Jen, no one talked to her husband about it, and certainly not her. So that's really great. So thank you all for coming to this. Thank you to Kaylee and Jen and Vanessa and Lee for agreeing to speak. And of course to Jen and Margaret for being amazing human beings and doing this for us. It's really wonderful. I was told that I was the only one and there weren't people like me, and that I needed to get used to that and be lucky and grateful that I was here. That led to me not wanting to be alive, just like Vanessa. And now I sit in a room with at least 8 other survivors that I can see on the chat. So don't believe everything you're told. How about that? Believe what you feel, like Kaylee was saying, and what
I
you know
did
to
see
be true.
one other question in the
Oh, you
chat
did?
from, is I don't know if it's Zara.
Oh, international advocates. Yeah. Oh,
yes.
yes. I think I met Zara. Zara, did I meet?
Yeah,
Kaylee,
it's
is this the
Zahara
Zara?
from
Oh,
this conference.
yeah. So Zara, I'm going to try to get somebody with resources to send me to you, because that's what I want to do. But yeah, we're going to come up with a Zoom, and we'd like to, Jen and I have stuff like that. So I'm going to get your contact from Kaylee, and Jen and I have some plans for that. So we'll email you. Thank you so much for messaging and asking that. Who trains the, just a question, who trains the trainer? That's a very good question. That's what Kaylee's trying to fix. Thank you, Xavier. That's a very good question. All right. Well, thank you all for coming to our first webinar. We really appreciate you all. There will be part 2. Please look out for the link, and we're going to try to put this on YouTube or send out the recording. So if you didn't get it, we'll get it to you, and look for emails. And if you have questions, please reach out. Don't be shy. This stuff lives in the light and it dies in the dark. So,
Amen.
all right. Bye, everyone. Thank you so much. Really
Thanks
appreciate
everyone for being here.